Officially, I am starting a series where we'll be discussing career progression for nurses and other professionals, just to see how people can progress in their different career, and just to make those who have questions about certain career opportunities, to have that knowledge. On today's episode, I have one of my colleagues in the hospital who is a critical care outreach nurse, not a critical care nurse, but a critical care outreach nurse. We had a very interesting discussion. All right. Let's get into it. All right, everyone. I have my friend here, and he's just going to introduce himself.
Hi, everyone. My name is Ben Udu. So currently, I'm a trainee advanced clinical practitioner with the critical care outreach team.
Interesting. I was really curious about your role because I've got people who are actually asking about other things I can do beside bedside nursing. Yeah. And I just said, let's have this show and see if you can explain some things to them. Okay. All right. Maybe we should start from where you completed your nursing school.
Okay. So I completed my nursing school in 2008 in Nsukka. It's a missionary school. Then I did a bit of normal hustling in Nigeria. I worked in Warri for 2 years, worked in Lagos, and then went to Jos University Teaching Hospital to do the 1 year intensive care nursing program. And after then, I went back to Lagos, worked for about 2 years, and then went to Abuja, worked with National Emergency Management Agency as ambulance paramedic.
That's a long list then. Okay.
2 years, and then before I came to the UK in 2018.
Interesting. So you have a background in ICU before coming to the UK?
So I am an ICU trained nurse back in Nigeria.
So did that influence your choice of department to work in when you came to the UK?
Yeah, so before becoming an ICU nurse, I had a colleague that I worked with while I was in Warri. So this particular colleague, he is very, very diligent and knowledgeable about clinical practice. So he has a way of dealing with patients and medication management. Like, for example, if a doctor prescribes potassium, an infusion that has potassium, he would ask me, Ben, what's the daily requirement of potassium?
Okay.
I can't remember. I said, okay. So you need to know the daily requirement of potassium before you give a patient any potassium. That you have to calculate the daily requirement and then make sure the patient is passing urine. And I can't remember being taught about these things in nursing school. And then we once had a patient with preeclampsia. We're giving the patient magnesium sulfate. So it was his turn to give these patients the magnesium sulfate. He decided to go with a patellar hammer. So I was like, why are you going with the patellar hammer? He said he wants to check the tendon reflex. I said, what's the relationship between the medication you are giving and tendon reflex? He said that he needs to check if the patient is passing urine. If the patient is not making good amount of urine, he's not going to give magnesium sulfate. And if there's absent tendon reflexes, he's not going to give magnesium sulfate. But where did you get all these ideas from? And he said he's an ICU trained nurse. Oh, so what do you guys do in ICU? So he started talking to me about ICU.
And this was in Nigeria, isn't it?
And this was in Nigeria. And these were actually the incidents that led to my interest in critical care nursing. And then I decided to go for the course just a year after meeting this person. Yeah.
Interesting. So let's come back to the UK now. So when you came to the UK, you started in ICU?
Yeah, so I started in an ICU. It is a DGS, it's a small hospital here in the UK, kind of a general hospital. The ICU is 8-bedded ICU. So that's where I started when I came to the UK. So I've never been to the ward. I've never worked in the ward. I've only worked in intensive care. And
was that like a general ICU or was it specialized?
Because it's a DGS, so they can only offer general intensive care. So we don't do trauma. We didn't do cardiac. We didn't do neuro. It gets referred to the tertiary hospitals. So I was there for 4 years. I was there during COVID and all that.
So at what point did you decide to go into critical care outreach?
Okay, so
because that sounded really new to me when I heard about it. Like, I know ICU nurses, but outreach.
Yeah, it's I think it started from, I never wanted to be a nurse. I've always wanted to be a doctor. So when I went to nursing school, it was...
Because that makes all of us.
Yeah. Yeah. So there was a plan to leave nursing at some point to go into medical practice. So then when I finished my nursing school, got a job, Nigeria happened. I couldn't get into medical school. I moved to the UK. My primary aim was to come to the UK, start work, and then go to medical school. So, but when I got to the UK, I started studying the educational system. I realized I need to get some certain qualifications to join the medical school through the graduate entry. And that will take me another 4 years of medical school. Then I'll become an F1, F2, SHO, and I'll start looking for
very
specialty,
long process.
and I'm getting old. So it wasn't something I decided to do. So I changed my mind. So, okay, if I can't get into medical school, what other areas can I get into where I can have clinical skills, work autonomously, and still progress in the band? And then during COVID, a lot of nurses, it took a toll on a lot of nurses, including myself. We're having patients dying every day without any. Our patients were not being discharged from intensive care. Our patients were dying on a daily basis, and people were really deflated emotionally and physically. So it took a toll on most of us, including myself. And
at this point, you're still in the ICU, general ICU.
Yeah, so a lot of people left ICU after the COVID. Yeah, so I got a band 6 role in ICU, and within the first few months of being a band 6 in ICU, I realized I am not really cut out to manage people the way it happens in ICU. So I'm more of clinical person. I'm not a people manager. So I said, oh, this is really not what
that's what band 6 really.
Yeah, so I was like, can I become a band 7 in this unit, in this role? I don't think so. Can I manage people as a 7 in this role? So I decided to look for something else. So while I was doing my ICU course, I did my ICU course at Coventry University. So while I was doing my ICU course at Coventry University, I had a placement in critical care outreach at the University Hospital Coventry. I also did placement in my own hospital. So I got exposed to this department called critical care outreach. I can see how they do their things, review patients, not relying on doctors, negotiating treatment plans and all that. So it actually caught my interest, and I said, this is the kind of thing I want to do. So, but then I had to sit back and plan myself. I want to grow in the bands. I want to practice autonomously, and also want to gain some education. So a role came up in Southampton, trainee advanced clinical practitioner and critical care outreach. So the role comes with apprenticeship, where you do a master's.
That's another question I have to ask you.
Yeah, so where you do a master's in advanced clinical practice in one of the affiliated university. So with the role, I was going to get a master's in advanced clinical practice, then get a higher band, and also practice autonomously. So it was one role that captures everything I've needed in clinical practice. So initially we started as a band 6, and then it progressed. Nationally we're supposed to be band 7s, but this practice is not uniform in the country. So
unfortunately.
So I started as a band 6 here, and then get up-banded to band 7. So when I qualify, I become a band 8. Yeah,
that's 8A.
8. Yeah, upon qualification. Yeah.
Wow. You guys, that's a lot of money. You did not mention that one.
There's no money in the NHS. Wonder there's no money in the NHS. We're serving the king.
But come to think of it, then it looks like those who go through the advanced nurse practitioner route, they get to the peak of their career faster. That's what I think sometimes, because now, like coming in as a trainee practitioner, you start at band 7, isn't it?
Yeah.
At the moment, that's what it is. Then when you finish your training, which is sponsored, you go on to band 8A.
Yeah.
Directly.
Yeah.
See.
Yeah.
Isn't that fast?
Yeah, no, it's fast, but comes with a lot of challenges. So the positions are very, very competitive. So the requirements for these roles are very competitive. Most hospitals want at least 5 years clinical experience, at least 2 years as a band 6.
5 years.
And then if you're working in any specialty, they expect you to have done specialty-specific courses. Yeah. So, and then in the UK here, you have a lot of nurses that have been in the the NHS for very long. They have all the knowledge and skills. So
competing against some of these people.
Competing with them is challenging, and then the university is also a very challenging one as well, because it's very intensive, and you're combining it with work. You're writing level 7 essays. We're doing presentations, and you're doing all kinds of, you teach people and you attend seminars, you do research, you do audits. There's a lot of things to do. And then you're also an independent practitioner. When you start prescribing, you also have to live to the expectation of people, making sure you prescribe the right drug, rationalizing your prescription, just like any other prescriber would do here.
Okay. The other thing I was going to ask really is, do you think somebody can go straight into being what you're doing, into your role, without having a background in ICU? Like, I mean, I'm just going back to when you started your schooling as an ICU trained nurse.
No.
So what if you don't have like that ICU training from nursing school?
Oh, it depends. So because that's why it is called advanced clinical practitioner. So it's not just nurses. So we have people coming from different. We just had a colleague that was in fire service, after fire service, ambulance paramedic.
Okay.
And now he did I think he did 1 or 2 years with trauma and orthopedics. And then now he's joining us as a trainee ACP as well.
So it's ACP now, not ANP.
So he's now.
You have told me this many times.
So it's advanced clinical practice.
Okay.
Because other clinicians who are not nurses are joining the role. So if you don't have ICU experience, you can actually join critical care outreach, but it depends on your wealth of experience. So I have a colleague from Nigeria. I think she's around here in Winchester. So she just got a Band 6 role in outreach in a hospital too, but she never had ICU experience, but she has had ED, AMU, and she did deteriorating patients.
It is a lot of experience.
Yeah, deteriorating patients. So if you have good acute care experience, say ED or ambulance paramedics, or if you've really been involved in AMU, proper AMU, not like you're not really, you know what I'm saying?
Yeah,
so you might actually be working in a ward, but you don't really know what happens there. Yeah. So if you're really into AMU very well, you can be brushed up. Your skills can be honed into critical care outreach. But critical care experience is a good one to have if you want to go into critical care outreach.
Okay, so would you then, well, from what you're saying, are you advising people now to go through ICU first before thinking of applying to the outreach role?
Well, I don't really advise people to do what I'm doing, because if I want to be very honest, it is a long journey, because I spent 4 years in ICU before I got a Band 6 role. So if you're joining a new ICU now, so you're expected to start as a new nurse in an ICU. So you have to do the ICU course. If you're joining a large ICU, you need to queue. You need to join the queue to do ICU course.
Someone has told me this.
Yeah, so it takes like about 2 years or more to do the ICU.
It's the same thing with ED.
Yeah, so when you finish the ICU course, then you must have stayed in ICU for about 3 or 4 years. And then they want you to have a Band 6 experience. So you start struggling to get a Band 6 experience in ICU, which is also very difficult. So it's a very long journey, except if you have other skills and experiences like ED. If you've been a nurse anesthetist in Nigeria, you can do critical care outreach. So if you've been nurse anesthetist, ED, but not ED in Nigeria, ED here, if you've had ED experience here, you can do critical care outreach. It's just to fine-tune your skills and you're good to go.
So what exactly is the scope of your work? Because I definitely know about critical care nurses, because I work in the ICU as more or less ward nurse.
Yeah.
But where does your role come in?
So the UK, they have this thing they called NCPOD. I don't know if you've heard about that. No. The National Confidential Inquiry into Patients as Commanded. So the Department of Health, occasionally they do inquiries. They want to know about quality of care in different services. So in 1999, they did a very popular NCPOD about critical care. So they were reviewing critical care. So they discovered that a lot of patients deteriorate in the ward some days before they die, and nobody actually noticed that they were deteriorating, about 60%. They also realized that the nurses in the ward don't have the skills and knowledge to look after such patients. They can't identify them. They can't look after them. They don't know the science of deterioration in the ward. So by the time the patient goes into ICU, the patient is already, patient won't be salvageable. So you need to take the patient to ICU in time if they really need to go to intensive care. So because of that, they now published a white paper in 2000 called Comprehensive Critical Care. So this comprehensive critical care recommended that a team, an MDT team that will provide equitable, safe, and quality care to patients. These patients are critically unwell patients, recovering patients, or deteriorating patients anywhere in the hospital. So they call it critical care without walls.
Right, outreach.
Yeah. So it's just outreach. It's an extension of intensive care, but anywhere outside
of ICU.
Yeah, anywhere outside of intensive care. So it's critical care without walls. So what we do is we identify deteriorating patients in the ward. We identify them early. If they need to go to intensive care, we facilitate them going to intensive care early enough. If they don't need to go to intensive care, if they need to stay in the ward for monitoring, we keep monitoring them, reviewing them from time to time. If we think this patient comorbidities, frail, elderly, not good functional reserve, we start thinking, can the team discuss about treatment escalation plans and maybe palliate the patient if the patient deteriorates further. Aside from recognizing deterioration, we also facilitate discussion around treatment escalation plans. We also follow up step downs from ICU. So every patient that have been to ICU and been discharged to the ward, we do a kind of follow up. So it's part of ICU rehabilitations. We want to make sure they are well in the ward because they are being stepped down from a higher level of care to a lower level of care. So we do follow up to make sure they are well in the ward. We also do formal and informal teaching to staff.
Right, teaching. Yes.
So we do a lot of formal teaching and informal teaching to staff. So we're supposed to be organizing things like deteriorating patient courses. We can be part of ALS. The other day I was teaching medical students about ESBA. So you get involved in a lot of
teaching medical students.
Yeah, I was teaching medical students about ESBA.
Nurse is teaching medical students. Take that to the bank.
Yeah, so we do those kind of teaching. Like my colleague was in maternity the other day teaching them about deteriorating maternity patients. So we do a kind of courses around. One of my colleagues does ABG teaching, another one does critical care transfer teaching. So we have kind of liaison. We are linked to different departments. I am linked to surgical department. I've not even had any teaching with them. I have loads of teaching. Teaching coming up. Yeah, so we do formal and informal teaching. We're also a member of the cardiac arrest team. So we attend all cardiac arrest except pediatrics. So be it maternity, be it Manova House, and be it in your lovely Victoria House.
Yeah.
We come. So we attend to all cardiac arrest calls. I think that's basically what we do.
Wait, just on a side note though, a question just dropped in my mind. Did you think you would ever have the opportunity to teach medical students if you were in Nigeria? Is that a thing in Nigeria?
Well, for me,
because I know doctors to be this.
Yeah, for me personally, I've been kind of very astounding. So when I finished my intensive care course and returned back to Nigeria, so I came back with a lot of knowledge because I was taught by professors. In Jude, we had a professor of surgery teaching us surgical intensive care patients. A consultant neuro teaching about neuro ICU patients. And so I came back with a lot of knowledge. Then I was challenging practices in the ED. I saw some of the doctors prescribing sublingual nifedipine to patients, and I was taught such is no longer in practice. Even in the US, it was banned as I think it was 1995, and it's still being practiced.
1995.
So we're doing one nursing meeting, and then I told them that I raised my hand. I was like, so sir, we need to really have a standing operating procedure about managing hypertensive emergencies. So we need to divide this hypertension. Is it urgency or emergency? If it is emergency, there is a guideline. And if it is urgency, there is a guideline. It's not about shoving an ifidip into all patients that has high blood pressure.
Okay.
So I've been really like the junior doctors. I do kind of informal teaching for junior doctor on a personal level.
Okay.
But I never thought about teaching them on a formal level. But because, as I said earlier, I'm doing this critical care outreach, which involves teaching both formal and informal. And then as an ACP, it's a different ballgame altogether.
Okay.
Because the ACP, Advanced Clinical Practice, we have 4 pillars. So there's advanced clinical practice, there is the research pillar, and then the education pillar, and then the leadership pillar. So part of the education pillar is that you have to teach people and you have to attend teaching session as well. So in your portfolio, you're supposed to fulfill a certain number of hours where you teach people and you get feedback from them. So part of fulfilling the ACP pillars is teaching. It could be medical students, it could be junior doctors, it could be. So we do teach junior doctors too as well. F1, F2, deteriorating patient, ABGs, alarm.
You see that's the good thing about the health system that is like integrated. Like nobody is feeling like they are
a boss.
Like they're this kind of boss that nobody can talk to them.
Yeah, it's all about the patient. What we do in Nigeria, we forget to, we don't realize that we are dealing with the patient. Patient is the focus and not anybody. So we go to cardiac arrest calls, and there are consultants that have never done IO, intraosseous, IO.
Yeah.
So because they are consultants, it doesn't mean they can do it. You can attend. You just grab it and do it. And then you can attend crash course. You discover an orthopedic consultant who has never led a crash call before is there. He will you can ask him, are you comfortable leading a crash call? If he's not comfortable, a nurse or any other clinician can step up and lead the crash call. It depends. That's why we have multidisciplinary teams. Everybody works in synergy. Yeah, unlike in Nigeria where certain group of people play gods or claim they are demigods in the healthcare profession. Yeah.
Anyway, that's on the side. That's on the side. Yeah, I'm going to ask you about, so with your role now, if you go out to like see patients on other wards, then how does it differ from the resource team? Are you people together or is it different?
We are different. So the resource team, they're only attending crash call. So so in the UK, there's a way the people organize their resource team. So there are people in certain hospitals. 2222 is cardiac arrest calls.
Oh.
Then
that's what we use for everything.
Yeah, this is what they use for everything in this hospital. Yeah. But in certain hospitals, in my previous trust, 2222 is cardiac arrest call.
Okay.
The fast blipping, it can be fast blipped if a patient is snoozing 7, and they call it acute care team call. It's ACT call. So there's an ACT call.
Okay.
There's another call they call a medical alert. So the patient using 5. So the people, like when you put out the call, it goes to the SHO, the F1, maybe possibly the medical reg if it's a medical patient, and then to surgical reg if the surgical reg, and the outreach team, but not the resource team. So the resource team will only attend to cardiac arrest. So if it's 222, it will come as 2222. Cardiac arrest in so area, 2222 cardiac arrest in so area. That's the area. That's the calls they attend. But in the hospital here, the 2222 is for all emergency calls. The resource team attends to all 2222. But they only work between 8 and 4 p.m.
Okay.
So when they are not in the hospital, we are the resource team.
Okay.
We are the resource team.
Okay.
Yeah. So then. Resource team, they are not ACPs. They have their own way of doing the thing. They do a lot of teaching, basic life support, trauma life support, advanced life support. They also do a lot of audit on cardiac arrest as well. So, but we work in synergy.
Just take us through what you do on a
day-to-day basis?
So our shift normally starts at 7:15. So we go there, take over from the colleagues on duty. It depends on what's happening. So our days are unpredictable. So you can just get into the office and you're just hanging your bag, and the next thing you hear is double two, crash gem required in so place. So that's how your day starts for that day.
Interesting. Okay.
Yeah. So there are still days you go in. So the normal day where there are no such emergencies, you go in, meet the previous team colleagues. They'll tell you about patients they've seen that are still in the list. So what we do, when we go to the ward, we are reviewing a patient, either because the patient is deteriorating or the patient has been on our list before, or the patient needs to go to intensive care, or the patient just returned from intensive care. So the ones that are deteriorating, we call them acute patients. So we get handover from all the acute ones, the ones that we need to see. They've seen them before, but we need to follow up and make sure everything is fine. And then we receive handover also from ICU step downs, like patient that left ICU the previous day.
Okay.
We need to do a kind of follow up in the morning for the patients. And then there are also patients called to be aware of. So probably maybe a doctor or a nurse calls you to say, oh, we have this patient been using 7 and we've done this and all this. Blood pressure is still very low. We just for you guys to keep him on your radar in case he deteriorates.
Just in case. Okay.
Yeah, so we get so many of those to be aware of. And sometimes we just go there to do a kind of welfare check, make sure the nurses are fine with the herbs, and make sure everything, patient has fluid balance charts, receiving the right fluids, making sure the bloods are done, electrolytes are replaced. And that's it. So those ones are quick fixes. But then you have patients that are on our list because they're call them dailies. So we review them. They're not getting better. They're not getting worse. So we just keep them as daily. So keep reviewing them on a daily basis. So after receiving this handover, you set out for your day-to-day. We do our equipment checks. We go to ICU to check if they've got bed space for admissions. And then we start our day. So we allocate ourselves. If we are two, some days you work alone, some days you might be two. So if you're working alone, you prioritize your care. And then if double two sounds around along the line, you drop whatever you're going and attend to.
And just attend to them. Okay.
And then we keep cracking until the end of the day. There are times you have like up to 2 hours when there are no bleep asking you to come and see patients. But there's still time where within 2 hours you have more than 4 crash calls to attend to.
Oh my God. What would you say is the most interesting thing about this role? So you tell us the most interesting thing and the most challenging things.
The changes you make to patient's life. So you go in now, they say patient is unresponsive, and they just, has this patient had any opioids? They say, oh, he had oxycodone. Can we give him some naloxone? Give the naloxone and the patient wakes up. But by then, a lot of people might be around the patient. The patient is not waking up. They are giving oxygen, and then when you turn up, your ICU thinking skill, your critical care outreach brain is, what are the likely causes of this drop in GCS? Opioids, any bleed. You now start asking what was the residual functional status before coming to them. So without even knowing what's wrong with the patient, you could actually just look at the patient and start suspecting something, and then recommend something they would do, and it changes the whole scenario. There are patients with COPD. You know COPD? It aims at 82 to 92. Yeah, because if you give more oxygen, it suppresses their drive.
Yeah.
So some of them will be in the wards. They are COPD. They are giving them oxygen. Before you know it, they sleep off, and nobody knows why they are sleeping.
They're sleeping off.
And they sleep from there, and they will become less responsive. And if you call me to come and see the patient, then I will ask, what are the background story to this patient? COPD, this, how much oxygen is this patient requiring? Say
that's really cool. Thinking about it ahead of time.
Yeah, so they're giving him 6 liters. Can we reduce this oxygen to 1 liter? Or can we turn off this oxygen to 1 liter? They turn off the oxygen, and by the time you turn up to the ward, the patient is awake already. Or there are patients that drop their sats and they're calling is using noise. Can we sit this patient up? It's as simple as that.
Like, so you have, as simple as that.
Yeah, so you have the knowledge of simple things to save patients' life. And when you apply them, it works immediately. So the fact that people are relying on you for your knowledge and your skill, consultants are relying on you, registrars are relying on you, other clinicians, physios are relying on you. If you review a patient, people respect that you've reviewed
the patient. Yeah,
so
they don't go back checking out what has it done.
No, some of them, when you review a patient, they say, "Oh, CCOT, thanks for your review." You see people come, "Oh, thanks for coming." So people are always grateful seeing you. The ward staffs are very, very, very happy.
But again, that's less workload for people like the registrars.
Yeah, it's less work. It's
and the consultants.
Yeah, it's less work. It's less.
They've got someone they can trust.
Yeah, it's less work for them. So the nursing staff, they find it easy to refer to us, and whenever we're around, they feel really safe. Some of them understand our own review more than some of the doctors. So they see us as people that review our patients systematically and make sure we have a plan, we follow up the plans. Like if I'm reviewing a patient in the wards, I will get to know the nurse looking after the patients and then ask the nurse about this patient. What do you think? Do you have any concern? And then I'll go and review the patient's bloods and everything and come back to say, okay, I'll review this patient. I think everything looks fine. What we can do is this and do this and do this and do this. I'll come back to see this patient again. If you have any problem, blame me. So that satisfaction that people rely on you, on your knowledge, on your skill, and you're able to make significant changes to patient lives is kind of rewarding. And then the challenging bits, there are so many challenging bits about the job. So the fact is, stepping into this role is very, very challenging. So when I joined this trust, I was coming from a small hospital. A small hospital is 8-bedded ICU. Here, I think we have more than 60 ICU beds.
Interesting.
So that's how big.
Did you say 16?
60.
60?
Yeah, the general ICU is about 30-something beds. I don't know how many in cardiac. I don't know how many in neuro ICU.
Yeah, I think neuro is probably the smallest. I've been there once.
So you'd be thinking about between 50 and 60 beds. So that's the difference between where I was coming from. So I have limited exposure to cancer care. I have limited exposure to trauma care, cardiac care as well. So if I'm on call and if I'm on duty and someone, a hematology registrar consultant calls me to say, "Oh, Ben, there's this patient in this cancer patient with B-cell lymphoma, had allograft and done this, is on social medication, there's this and that," and then start mentioning some of the cancer drugs and the condition of the patient. The patient is now in myelodysplastic syndrome, and what is this man saying? You don't even know what they are saying. So then you turn up to see this patient and they're going to review this patient with a consultant. That's really challenging. It's also challenging because every time you go, there is no pre-information. You meet fresh unfamiliar cases every now and then. So is you having to step up in that role. Another challenge there is also the communication between you and other clinicians, because most times you end up communicating mostly with registrars, consultants. So at least you need to know your onions to be able to, if you want to refer to an ICU registrar, you want to talk to an ICU consultant. Imagine. So if you're in the ward struggling patients, low blood pressure, and you want to call ICU registrar, they say, "Talk to me about this patient. What is happening? Do you think this patient needs to come to ICU?" The ICU consultant and registrar are relying on you say, "This patient needs a," so you can. So you have to be at that level to be able to perform. And then challenging part also is clinical knowledge as well. Not just knowing part of physiology, but really knowing how the apply in real life situations. Like you do low blood pressure, its relationship with urine output, with the renal circulation, relationship with blood, cerebral perfusion. It's just knowing how those things work and the likely consequences if something didn't happen. Like a patient that has a sort of 70s and people are now concerned about giving oxygen, you know that this patient will go into hypoxic brain injury if you don't do something. So knowing this thing and knowing the likely outcome of these things,
I'm being lectured.
there are the challenges. And another challenge is you work alone. You're going to work as an independent practitioner. So working alone means you will face difficulties, you will face racism. There are some people, when they hear your voice on phone, once they hear your accent, they've lost faith in you. So you face racism, you face kind of discrimination as well, and then you'll be on the edge on so many days. You make mistakes, you learn from it. But if you're working alone, it becomes really more difficult. So because you don't really have anybody to fall back on. We are part of the IC, but we're not really part of the IC. You only call the ICU registrar if you need to. Otherwise, you're on your own. Then if you have a second person working, that's fine. But most time you're on your own.
Wow. You mentioned something earlier. I think I forgot to ask further question on it. So you said you did. Are you still doing the ACP training? Or you finished?
Yes, I'm still a trainee.
They say training.
Yeah.
So is that compulsory for you to pay an outreach?
ACP.
Yeah, the ACP training course.
So there are different hospitals that are using different models for their outreach service. Some people, their outreach practitioner are their resource practitioners. And some people, their outreach practitioner also their hospital out of hours practitioners. Okay. So some hospital that are using pure ICU nurses. In my previous hospital, they don't have outreach nurses. What they have is every band 7 in the ICU will rotate to do outreach shifts. Okay. So they don't. So in-house, they will do some modules like prescribing, health assessment, and then continue working. Those can do in the university and continue working, but they are not doing the advanced clinical practice. So, but in a hospital, we do advanced clinical practice. So with advanced clinical practice, you have to be a trainee. So you have to be a trainee, and what we're doing is apprenticeship. So there are 2 pathways to becoming an advanced clinical practice. You can do through the modular pathway or the apprentice pathway. The modular pathway is where you just register with the university, you do module by module. But the apprentice pathway, you have to, is sponsored by NHS England. So it's a national, almost like you're doing national apprenticeship. So you work a minimum of 30 hours. Your contract must be a minimum of 30 hours. You have compulsory 7.5 hours every week for study. So you have 80% of your hours for clinical work, and then 20% for study. And then you have to go to university for the period. And apprenticeship for ACP is normally 3 years. So for you to work in the team, the job comes as trainee advanced clinical practitioner. So you have to be a trainee and you have to do the university. So it's compulsory once you take the role here in a hospital. But other hospitals have different models for critical care outreach.
So who would you say this career path may not be suited for? Like, do you need a special kind of personality?
Well, if I would say about personality, I should be thinking about someone who is very quiet and timid. But unfortunately, I'm a very quiet person. But I'm doing the job. So even if you're quiet, you can still do the job. It's about stepping up. If you don't have good background knowledge, clinical knowledge, like good anatomy knowledge, good physiology knowledge, good basic biochemistry, good basic pharmacology, it will be difficult for you.
So that could be something like somebody can just learn on their own, isn't it?
You can learn on your
just go
own.
Back and
revise them, but linking them to practical terms, like, patient has low magnesium and low potassium. what are the clinical significance? What
Okay.
can it? What are you concerned about?
Yeah.
So if I see a patient with a very high heart rate, I'll run to the electrolytes.
Okay. Yeah.
So if I run to the electrolyte, check magnesium, potassium, calcium, sodium. If they're all right, I'll check, are they in pain? And have they done a 12-lead ECG? So some of these things link directly in one way or the other, directly or indirectly. So having those kind of basic clinical knowledge, if you don't have it, it might be difficult to learn that on the job because it's fast-paced and you're trying to manage yourself and the patient at the same time. So if that's when you start thinking, oh, magnesium is good for the heart, patient might have gone into AF and dropped their blood pressure and about to rest, but you don't even know why and how. So if you have very poor communication skill, it will be very difficult.
Okay.
So when I mean communication skill is both written and spoken communication. So you have to talk a lot with patients, you have to talk a lot with nurses, you talk a lot with doctors, and then you document a lot. You should be able to have a very clear documentation. Say this is what you've reviewed. You reviewed your patient. You document your review, your findings. You have a discussion with other colleagues. Make it very clean and concise. Say, if you don't have a good communication skill, you will struggle. You need to be physically active.
Right.
Yeah. So being physically active is like we have a B to G level. So if you can't attend to crash call in G level and then attend to one in B level and one in F level, it might be difficult. And there are times you need to move equipment like carrier-wire intubation, trolley, ventilator, and all that. So you need to be very physically active and resilient. There are days we may not have breaks. So if you're working alone, you may not have breaks. So from reviewing one patient to the other. So you need to be physically fit to do the job, resilient physically and emotionally. You also have tragic shifts, like shift where patient crashed on you, patient died and things like that. There will be things like that. There will be times you really say you have to be physically and emotionally resilient. If you're not a fast thinker, the job is not for you. You have to always think on every time. You have to think very, very fast and do something. So you have to be a fast thinker. I think these basic things. Otherwise, if you gain good knowledge of good clinical knowledge and basic biochemistry, critical care is good, but it's not compulsory. Initially, it's one of the essential skills. Before you get the job, you must have a critical care course. But now we have people coming from ambulance paramedic. In my previous trust, there was a band 7 that he worked in ambulance for 24 years and joined the trust as an outreach and worked 1 year and then become the resource lead for our trust. So it depends on, but they now accept people without critical care outreach. Then when jobs like this come up, what I normally do is to look at the essential criteria.
Okay.
So if you look at the essential criteria, if it is something you can do, you apply for the job. If it's not something you can do,
just leave it alone.
No, you can work towards it. If it is something you want to do later, you can work towards it.
Okay.
You can work towards it. If there are courses they ask you to do, like the lady that got one in Winchester, she did the adult deteriorating course. Is it adult deteriorating course or deteriorating adult?
Adult course, yeah.
One of them.
Either way.
So she did the course. So that's an added advantage. So even if she doesn't have an ICU experience, but she had AMU and ED and I've done this course.
Right.
So if somebody is coming from ICU that have not done their ICU course, they will still prefer her because she's had ED experience, AMU and done the course.
Done the course, okay. Yeah. Okay. So now that you are a critical care outreach nurse, what does career progression look like beyond this point?
Okay, beyond this. So when it comes to the aside, so
this is band 8A now.
Yeah, that's what it will end.
It will end when you finish your ACP course.
Yeah. So there are two things here: critical care outreach and ACP.
Right.
And I'm merging both of them.
Okay.
So ACP, they already have their own career pathway. So you become an advanced clinical practitioner upon qualification, band 8A. And then as time goes on, you can get band 8B, depending on what comes up and all that. But on the side of critical care outreach, so we have an organization called National Outreach Forum.
Okay.
So they kind of set up competencies, a competency framework for critical care outreach. So there are 3 levels of critical care outreach practitioner. So you have the enhanced practitioner, which is between
first ED,
first let's say 1 year to 18 months. Then you have advanced critical care outreach practitioner, which is what you become when you become a band 8A, and then the consultant critical care outreach practitioner.
What band is that one?
So it depends on what the job comes at. So there are consultants that are 8C and there are consultants that are 9s. So it depends on
that's consultant nurse.
Yeah.
Or clinician nurse.
Yeah.
Practitioner.
Whatever the role says. So it's also that's what I was saying. It is both ICU.
I cannot wait.
So it's both critical care outreach and ACP. So ACP too, you can become a consultant in ACP, consultant practitioner in ACP. There is one prof here in ED who is a consultant, also a prof. A nurse. In our ED, yeah. I've not met him, but he's a well-known prof. One of the renowned professors in nursing and consultant as well. He's a nurse consultant. So you can become a nurse consultant as an ICP in ACP pathway.
Yeah.
You can also become a nurse consultant in an outreach consultant in outreach pathway. Do you get it now? So there are two pathways. So if I decide to leave critical care outreach now with my ACP, so I can do ACP in AMU.
Right.
If I need to do ED, I'll have to do the RChem. They have the Royal College of Emergency Medicine. They have the competency framework.
Yeah.
So the ACP that each specialty have their own framework. So the RChem, the Royal College of Emergency Medicine, have their own framework. So if you want to be an ACP in ED, you have to do their competency framework and fulfill their competencies. Then in ICU, they have the ACCPs, which is credentialed by the Faculty of Intensive Care Medicine.
Okay.
So if you can become senior ACCP, and if there's a role like consultant ACCP, you can become consultant critical care practitioner.
Thank you so much. Just one final one. Okay. I think we've dealt with everything really, because the only other thing I have here, which I think you've touched on, is what advice would you give someone who is interested in this career path? I believe you've said a lot of things about.
Yeah, but I can make it more concise. Okay. So if you want to do critical care outreach, it depends on where you're starting. If you're already in the UK and you're already in a pathway, the thing is, as a nurse or whatever you do, you need to have your own pathway, not what people are doing. Yeah. So
not what people are doing.
No, because everybody, not because I am in outreach, you want to do outreach. No, have your own pathway. So if you're already on your own pathway and you want to become an ACP or you want to become an outreach, at least get a band 6 in your pathway, in your specialty. Then look for courses like this deteriorating adult course. Is a good course to do. You can do it as a level 7. Do it as a level 7. Pick bank shift in ED. Get ED experience.
Bank shift helped me a lot. I cannot even.
Bank shift is very, very good. Pick a bank shift in ED and then start speaking to people doing this job. If you see an outreach practitioner, talk to them. Ask for a shadow shift. You can come for a shadow shift and then see what's happening. It's always better to test before buy. Then you start asking if there is a secondment somewhere. If there's a secondment in ICU or ED, go for the secondment. And then get the experience. So once you've gotten the experience, you can start thinking, so what are the essential criteria in this job? Have you met them or do you need to work towards them? If you're starting afresh or you want to go through ICU, it's fine. But then if you're going through a large ICU, a big ICU, it means you will take a longer time, and the time it takes for you to become a band 6 in ICU, someone in the other world become a band 7 or so if they are really progressing in their career. So it depends. And then get your credential. If you don't have a bachelor degree, you can do level 6 or level 7 courses. I don't have a bachelor degree. So you can do your level 6 and level 7 courses here, so that when you apply for the job, you'll be telling them you studied at this level. And if you're going for the ACP for apprenticeship, you must have stayed in the UK for 3 years. Yeah, because you need to be considered as a home student before you do your ACP training as an apprenticeship. Yeah. So you need to have stayed here for 3 years. If you are not stayed 3 years, I'm not sure they'll be able to enroll you in school.
Does the pathway for the ACP?
The apprenticeship. Yeah. Because apprenticeship is a national way. They have the National Technical Education and all that do a kind of apprenticeship, including younger ones. Yeah, so you have to be seen as a home student. You can't be
an international
student to do. It's not for international students, so you must have stayed there for 3 years.
What I was thinking is, if you are going through the NHS, there shouldn't there be like a way for them to consider you?
No. So even if you have stayed here for 3 years, you still have to show them a visa that is valid for another 3 years till the end of the apprenticeship.
I see.
So if you fulfill the hospital requirement and gotten the job, fulfilling the university requirement is a different thing altogether. You do a lot of paperwork with the university, because they're also required to meet those standards as well.
Okay, I think it's a good thing I'm over 3 years now, so just in case. Anyway, thank you so much. This was insightful. Well, like over an hour now.
Yeah, you've drained all my energy.
Thank you so much. Guys, I hope this was really helpful for you. And if it's something that you're interested in, or you have any other question at all, please put in the comment section. I don't think I've heard about this pathway like this before. Yeah, so it's been an amazing time with you. Thank you so much for coming.
Thank you, sir.
Thank you. All right. Let's wrap it up here.